Lisa, Mona Lisa min lonely. You're so like the lady with the mystic smile. Is it only 'cause you're lonely they have blamed you for that Mona Lisa strangeness in your smile? Do you smile to tempt a lover, Mona Lisa? Or is this your way to hide a broken heart? Many dreams have been brought to your doorstep. They just lie there and they die there. Are you warm? Are you real, Mona Lisa? Are just a cold and lonely, lovely work of art. Smile to tempt a lover, Mona Lisa? Or is this your way to hide a broken heart? Many dreams have been brought to your doorstep. They just lie there and they die there. Are you warm? Are you real, Mona Lisa? Are just a cold and lonely, lovely work of art. Mona Lisa, Mona Lisa. The very thought of you and I forget to do the little ordinary things that everyone ought to do. I'm living in a kind of daydream, and I'm happy as a king, and foolish though it may seem to me, that's everything. The mere idea the longing here for me. Yes, but you never know how slow the moments go till I'm near to you. I see your face in every flower, your eyes in stars above. It's just the thought of you, the very thought of you, my love. Stars above.
Good afternoon, everyone. We're ready to begin the program. If you'd like to take your seats. Welcome and thank you for coming to the ALS Ask the Experts Living with ALS. My name is Giovanna D'Angelo. I'm the Director of Special Events for the ALS Association Golden West Chapter. We have a great program planned for you today that we know you will find very informative, discussing important aspects in clinical care and promising developments in research. Please let's take a moment to say hello to all the people who are watching today via the internet. Everyone wave and say hi. Great. Today's event would not have been possible without the support of our sponsors. I would like to thank ResMed, Superior Mobility, Home Respiratory Care, Permabil, Toby, and Beauty Bus Foundation, who are all here today, so please make sure you stop by and visit the booth during the break. I would also like to take this opportunity to thank the tireless efforts of the team here at Cedars to provide us such a wonderful venue, especially Alan Jensen, without which none of this would have been possible. Is Alan here? Where's Alan? He's up at the booth. There you go. Yeah. Great. Finally, please allow me to introduce the dedicated staff of the Golden West Chapter, each who have worked tirelessly every day toward our vision for a world without ALS. Our President, Fred Fisher, and CEO, will be joining us a little bit later today during the research portion of this event. Madeline Thompson, our Director of Care Services. Madeline, can you, right here, thank you. Jenica Lancy, our Director of Marketing Communications. We have Julie Hennett, who's our Regional Director of Signature Events. She's outside. I think most of you met her during registration. Jamie Aronson, our Assistant Event Coordinator, is over there by our Augmentative Communication. And Lindsay Crawford is, there she is. And Cheryl Goldstein, our Development Director, will be joining us later today as well. We have a couple of our care managers and support group leaders here joining us. We have Jennifer Claxton. Our new care manager for Ventura County, Barbara Bosch. We have Melissa Gonzalez. She's here as well. She's going to be taking over the position for Pedro Lozar. And then Martha Mowat, who's our support group leader. Great. The program format for this afternoon will be as follows. The first session will focus on important aspects in clinical care. Each speaker will make a 20-minute presentation with a 10-minute Q&A. Please note that we will need to allow for time for questions from our internet viewers as well. There will be a break at 4:30 to 5 p.m. For those of you here in person, there will be some light refreshments and a chance to visit with the vendors. For those on the internet, stay tuned as we will have some videos about our chapter for you to view. The program will reconvene at 5 p.m. for the second session, Research Updates. Each researcher will give a 10-minute presentation on the latest development in research in their area of concentration, followed by a 5-minute Q&A. At the conclusion, all the researchers will come together for a 10-minute Q&A session. So let me begin by introducing our first presenter. Dr. Catherine Lomen-Hoerth is an associate professor in residency in neurology at UCSF. She is the director of the ALS Center at UCSF Medical Center and ALS Association Certified Center of Excellence in ALS Care. She received her bachelor's degree in biochemistry from the University of Arizona and her MD and PhD at Stanford University of Medicine in neuroscience. At UCSD, she served as chief resident in neurology and completed a fellowship in electromyography and neuromuscular disorders. She is particularly interested in research involving electrophysiology and genetic predators, is that? Predictors, okay, mouthful, in ALS. She also is interested in the overlap of ALS and frontotemporal dementia, a related neurodegenerative disease. She is certified by the American Board of Psychiatry and Neurology and is an advisory trustee of the Golden West chapter. Ladies and gentlemen, Dr. Catherine Lomen-Hoerth.
Thank you very much for inviting me to speak. I'm going to be talking about multidisciplinary care in ALS. And the reason that it is multidisciplinary is because, as you know, ALS can affect any part of the body, whether it starts with difficulty with speaking or swallowing, or starts with weakness in an arm or in a leg. Eventually it can progress to requiring care for all of the different areas affected. And I think most people are familiar with the way ALS is diagnosed. It's typically a combination of upper motor neuron loss and lower motor neuron loss. Upper motor neuron loss causes slow speech, brisk reflexes, stiffness of the muscles. Lower motor neuron loss tends to cause cramps, fasciculations, atrophy, weakness of the muscles. And these two things together are what classically we refer to as ALS. Of course, patients can sometimes have a purely upper motor neuron process or purely lower motor neuron process, but that's more rare. So once the diagnosis is made, it's important to start treatments, both treatments to slow the disease process. And for that, we have Riluzole, which is the one FDA-approved drug to treat ALS. Then we think about treating the various symptoms of the disease. So managing respiratory problems, managing swallowing difficulties, treating some of the symptoms such as excess saliva, mobility issues. And ultimately, we think about palliative care. The American Academy of Neurology has produced some wonderful guidelines that were recently updated that really go through each of these symptoms and help explain to neurologists what is the standard of care for all of these different things. As far as poor nutrition, the causes can be multiple. It can be a swallowing issue, but sometimes people's swallowing is completely normal, and people have issues around arm weakness or shortness of breath that are contributing to their nutrition issues. There is increased energy expenditure as well with ALS. So solutions depend on where the problem is, but breathing support can help, eating aids. We really recommend a high-calorie, high-protein diet and often recommend nutritional supplements such as Ensure Plus or Boost Plus. We suggest modifying food consistency to have a softer diet if it's difficult to swallow. And ultimately, many patients may need a feeding tube to be able to get supplemental nutrition. Doesn't mean people have to stop eating. That's a common misconception. But the feeding tube allows you to get supplemental nutrition to maintain your weight. As far as breathing, there also can be different causes. Diaphragm weakness is the most common cause, but patients can have chest muscle weakness. They can also have increased energy expenditure, which causes shortness of breath. And solutions include breath stacking exercises to help expand the lungs, using a non-invasive positive pressure ventilation. Diaphragm stimulation is an experimental treatment that's being investigated in more detail. And then ultimately, patients may choose invasive ventilation, or they may choose to use a ventilator non-invasively. That's becoming increasingly popular. But supporting the breathing alone can prolong life a significant amount. It can prolong life much more than Riluzole, which is the only drug that we have approved to treat the disease. So it's very important when your doctor recommends that you consider breathing support to take it seriously, because it's one of the best things you can do for both your quality of life, to help improve energy, and also for your longevity. The next, when we think about the various symptoms of ALS, they're really quite multiple. I've mentioned muscle cramps and fasciculations. Patients can have stiffness, trouble with depression, fatigue, constipation, difficulty sleeping, excess saliva, anxiety, dry mouth, thick phlegm, labile affect or easy laughing and crying, urinary urgency, and laryngospasm. And this paper shows the % of ALS patients that had these various symptoms. So I'm going to go through a few of these and talk about what we do as far as treatment. For cramps, we like to recommend conservative things such as massage, hot baths, stretching. As far as medications, Tegretol and Baclofen are often used. Mixilotine is another treatment. Quinine sulfate is a very effective treatment, and in the U.S., this is termed Qualocrine. That's the commercial name for it, and sometimes can be difficult to get if insurance won't cover it. But you can still get quinine sulfate from Canada, and if you have very mild symptoms, tonic water contains quinine, and that may be effective for some people. As far as spasticity, it's a balance between being too loose and too stiff. If you relax the muscles too much, then you can have difficulty walking. So we recommend these various treatments such as Baclofen, Valium, Dantrolene, Memantine, and Tizazidine. We recommend that you gradually go up on them, and when you get to a point where you feel too loose, then it's time to back off. Sometimes we use these medications and patients still struggle with spasticity, and in that case we consider a Baclofen pump, where a small pump can be implanted and then the Baclofen is delivered directly into the spinal fluid, and that helps the muscles relax without having the problem of the sleepiness from some of the medications. And then lastly, Botox can sometimes be used for very focal areas of spasticity. Excess saliva can be treated with atropine. It can also be treated with amitriptyline or Elavil. Glycopyrrolate or Robenol is another effective treatment, scopolamine patch. And radiation therapy is more rarely used because that's a more permanent solution, and we certainly don't want to overshoot. But one of the most popular treatments is Botox. The Botox is delivered every 3 months and helps to dry up the saliva, and then there aren't the side effects of the medication, such as constipation or excessive dry mouth. In terms of thick saliva, we often use Robitussin, just plain over-the-counter the Robitussin. Increasing fluids is effective, and then sometimes using therapies such as a cough assist machine can help to mobilize those secretions. Pseudobulbar affect is the name we use for easy laughing and crying, and while it is fairly hard to diagnose, it's very easy to treat. So traditionally we have used treatments such as Elavil or amitriptyline, but just this last year a new drug was released to treat this symptom called Nudexta, and you may have heard of it. It's a combination of dextromethorphan and quinidine, and interestingly investigators now are studying the same drug to see if it might be effective at helping with speaking and swallowing. There's some anecdotal reports that it may help speaking and swallowing. So investigators are now researching the drug for that effect as well. But it's extremely effective for the easy laughing and crying, stops it almost immediately. I'm just having a little trouble advancing the slides. I don't know if someone can advance them for me. So urinary urgency. We think about the anticholinergics to treat this symptom. Medications such as Detrol and Vesicare are quite effective. If medication's not desired, condom catheters can be used, and then sometimes people think about actually having surgery to have a suprapubic catheter placed. There are also male and female urinals that can be used, but it's a significant problem, and it is quite easily treated with medications or with some of these other measures. As far as depression, it's important to exclude other things that can mimic depression, such as a respiratory problem, poor nutrition, poor sleep, or just appropriate reaction to the diagnosis. We think about referring to a counselor, and then we definitely do start antidepressants when needed, particularly when it's starting to disrupt sleep or affecting appetite. So speaking of sleep, most ALS patients' sleep problems are mechanical, so making sure that there's a good, very good bed, that there's appropriate breathing support, and we often start with very mild treatments, over-the-counter treatments like valerian, and then if that doesn't work, then we think about some of the sedating antidepressants such as Remeron or Trazodone. And then lastly, we think about trying some of the benzodiazepines such as Valium to help with sleep. As far as constipation, we typically increase fluids, increase fiber, consider stool softeners, consider Miralax or Lactulose. Those are all very safe things to take to help with constipation. And then lastly, as far as weakness, this is going to be discussed in more detail by a little bit later in the day, but just to say that it's important to optimize both home and work environments. It's important to anticipate equipment needs before the equipment is needed so that you're not rushed. Driving assessments can be performed to make sure you're safe with driving. And then lastly, exercise is important. And so I'll just mention that there are free work assessments through AT Network where they'll come into your work environment, assess what's needed, and provide equipment. And there are also specialty contractors if your home needs to be remodeled. And lastly, even through hospice, they can provide some sources of equipment as well. We'll hear about the equipment advances in the next talk, and so I'm going to skip that slide. As far as exercise has been shown to prolong survival, to help with quality of life, to reduce spasticity, and to strengthen some of the muscles that are stronger, as well as elevate mood. So there are a lot of positive effects of exercise. This is a study that was done looking at daily stretching and mild resistance exercise in 27 ALS patients, and after 6 months, their quality of life was improved, their functional rating scale was better, and their muscle strength declined more slowly. It's very important for me to emphasize, though, that you do not want to overwork a very weak muscle. So if it's difficult for you to move a muscle fully against gravity, then that would not be the muscle to be exercising. It's muscles that are stronger that you want to exercise to help compensate. And then in terms of very end-of-life issues, I think it's really important to think about that throughout the disease process. It's something I always discuss on the day of diagnosis so that people are prepared and know what's ahead. It's good to enroll in hospice as soon as you're eligible because they have so many different services they provide besides just end-of-life services. And we utilize home care a lot to assess what's needed in the home so that you're safe. And then it's important to continue to follow in an ALS multidisciplinary clinic even when in hospice, because there are so many recommendations they can make that can then be translated back to the home care agencies, hospice agencies, and your local providers to make sure that you have everything possible that you need to help optimize your function during this disease process. So in the last moments of my talk, I'm going to turn to a slightly different topic, and then I'll open things up for questions. I mentioned that ALS classically has both upper and lower motor neuron damage, but in addition, in some patients, there can also be cognitive or behavioral problems. And this is the percentage that's been reported as far as patients that have either cognitive or behavioral issues, anywhere from around 20% up to almost 50%. And in a study we did at our institution, we found that about half of the patients were completely cognitively and behaviorally normal. About 20% had some sign of met criteria for frontotemporal dementia, and I'll talk a little bit about that. And then the other quarter weren't completely normal, but did have some cognitive or behavioral problems. And so this can be shown on imaging as well. On the right-hand side are ALS patients that are cognitively and behaviorally normal, and on the left-hand side are patients who are not. And you can see that in the red, those are the parts of the brain that are atrophied. And in the front and side parts of the brain, there's more atrophy in those patients that have ALS and cognitive and behavioral problems than those that do not. And this is seen pathologically as well. There's a protein that you'll hear about later today, TDP43, that is known to be the major pathology found in both ALS and FTD. And it's found not only in the spinal cord and in the motor areas, but also in the front part of the brain and the side parts of the brain, which are involved in controlling behavior and cognition. And so this link is very important because there was an exciting discovery in 2011 with the C9orf72 gene. It's kind of a mouthful, but this particular gene is found both in ALS and in frontotemporal dementia. And in fact, it's responsible for almost half of the familial ALS cases, many of the FTD cases, and it's even seen in sporadic disease. So there's clearly a connection between these two disorders. Well, I mentioned that I would come back and explain what it is. So these are some of the symptoms. And it's not really new, but I think that we understand more what some of these symptoms may be. Now, I want to be careful to qualify that the symptoms on the left-hand side of the slide are very appropriate reactions to having the disease. What we are concerned about is when it's beyond that, when family members say, this doesn't seem quite right, this doesn't fit with their normal personality. And when it gets to that extreme, patients can become apathetic, disinhibited, have poor judgment, become easily frustrated, quick to anger, have lack of insight into their disease. They may have language difficulty, like word-finding problems, spelling problems, and aphasia. And so there are many things, of course, that can mimic this as well. Depression can mimic this. The pseudobulbar affect that I mentioned can mimic this. Patients can have uncontrollable anger outbursts that are treatable. Patients can have lack of oxygen or have difficulty retaining CO2. And then someone's baseline intellectual function may confuse the process as well. And then as patients have more difficulty speaking or more difficulty with moving, doing the testing can be hard. And then, of course, as the disease advances and communication becomes more difficult, it can be even more confusing. So it's important to make sure that everything is optimized and that some of these various things have been excluded. So is this important? I mean, why are we worried about this? Well, it is important because we thought that the survival might be shorter in patients that had ALS and frontotemporal dementia compared to ALS alone, and we thought that compliance with treatment recommendations might be less. And so we tested this and found that in ALS patients, the survival indeed is shorter by about a year when patients have associated FTD, and other people have found this as well, even in very mildly impaired patients. And it kind of makes sense because what we found is that when patients have the associated frontotemporal dementia, they tend to refuse a lot of the recommendations, such as PEG and BiPAP, whereas for those patients who do not have this symptom, they tend to be more accepting of these important recommendations. And so lastly, there are very important clinical issues with this association in that there is a reduced survival rate, there is the poor compliance rate with recommendations. There can be a lot of caregiver distress if someone's falling all the time and is refusing to use a cane or a walker. That can cause a lot of distress. And patients often have a very poor safety awareness. They may choke on food frequently because they're putting too much food in their mouth. They may have trouble making important decisions. And there are implications for stem cell therapy because as we think about stem cell therapy going forward, that's going to help the cells in the spinal cord, but it's not necessarily going to be affecting the cells in the brain. And so we have to think about what will happen if ultimately we can really help the function of the arms and the legs, but we aren't fixing the problem that's going on in the brain. So I think there's quite a few implications for this, and in summary, there are medications available to treat many of the symptoms of ALS, as I mentioned. Equipment advances can help patients be more independent than ever, and we'll hear more about that going forward. Multidisciplinary clinics have been shown to improve both quality and quantity of life, so it's very important to be connected to a multidisciplinary clinic if you have an ALS diagnosis. And then it's important to be aware of cognitive and behavioral impairments that impact survival and management. And in closing, I would just like to thank all of the people here and back home that work on the multidisciplinary ALS team. I certainly could not do this job without all of their help, and we're very grateful also to have our associates such as the ALS Association to help us. Thank you very much. Any questions that anyone has? Yes.
Could you explain to me what breath stacking is?
Yes, it's an exercise where a bag, so that sort of looks like a balloon, is placed over the mouth, and then you inflate this bag, and basically it inflates the lungs, and then you remove the bag and blow it out. A respiratory therapist would have to show you exactly how it's done, but it can be helpful both for secretion clearance and also just to help exercise the lung. There's certain types of respiratory devices that can be done on as well. The sip and puff ventilator can be done through that as well. So it's worth discussing with your respiratory therapist. Any other questions? I think we also have people on the internet, so I don't know if any of them have questions. We may wait a moment for that.
We have to wait just one moment, but there was one statement that said, "Thank you so very much, Dr. Lomen-Hoerth."
Okay, thank you.
Just 1 second. Okay. All right.
And thank you for coming. I think you're going to enjoy the afternoon. There's some very exciting talks coming up as well.
You have a question?
There's one question that said, could you please explain in more detail what a multidisciplinary center is?
Sure, I'd be happy to. Maybe I can go back to my last slide if I can. A multidisciplinary ALS center is one in which there is a whole team of specialists, typically a neurologist, an ALS nurse, a social worker, a dietitian, a speech pathologist, who may or may not be a communication specialist. If not, there's often a communication specialist as well. There's a physical therapist, an occupational therapist, and these specialties that I've mentioned are specialists that are required to be certified by the ALS Association. So if you go to the ALS Association website and type in your state, you can search for the clinics that are in your area that have that full multidisciplinary team. And I think that's so important because the disease is so multifactorial. Oftentimes there's other people associated with it, like such as a psychologist, a rehabilitation physician, a pulmonologist, a gastroenterologist. So multidisciplinary care isn't really new to ALS. It's used in a lot of other diseases such as cystic fibrosis, multiple sclerosis, but it's very important for this disease. And the studies that I mentioned that showed that multidisciplinary care improved quality and quantity of life, that also was done all in a multidisciplinary clinic. So we have both a question from the audience and a question from the internet.
The question from the internet is, how often should a person with ALS exercise their lungs?
I think that would be something you would have to discuss with your respiratory therapist, because depending on if there was any other coexisting lung disease such as emphysema, you'd have to perhaps be a little careful. But I know that our respiratory therapist will often recommend breath stacking 2 or 3 times a day if someone has the energy to do it. Yes.
Is there any hope of an earlier diagnosis on the horizon?
I think that's a great question. I think that we are working towards an earlier diagnosis in terms of trying to find blood biomarkers that might help us identify patients earlier. I think right now the biggest limitation isn't so much when someone gets to a multidisciplinary clinic having the diagnosis be confusing. I think it's people with ALS symptoms not getting to a multidisciplinary clinic soon enough. And so patients that I see typically have had their symptoms for at least a year, and they may have gone to 3 or 4 different neurologists who are very puzzled about what's going on since ALS is such a rare disease. So I think the hope of an earlier diagnosis, I think, is spreading the word, and so that people who know what the symptoms of ALS are and can get seen sooner at a center where they can be diagnosed. Yes? I can repeat the question. So this is a woman who's mentioning that her brother has ALS, and they found out that their uncle also had ALS.
And he passed away.
And he passed away. And how old were your parents when they passed away?
74 and 78. 74, and they both had Parkinson's, but
our uncle had ALS and our brother does. And so I just wonder, is there a correlation with research in families?
Yes, so ALS runs in families around 10% of the time, and usually it's quite strongly it's quite strong in that the parents, a parent usually has to have it and then the child has to have it. But I think where it gets confusing is that sometimes ALS can start very late in the 80s, and so you always worry, well, especially when you have two family members that have the disease, like in this case the uncle and the brother, could it be that one of the parents would have gotten it later in life if they had? I think the best recommendation I have, because we know so many more genes now that cause the disease, is to go ahead and get testing. Have your brother be tested and see if he has one of the known genes, and then members of the family can choose whether or not they would like to be tested. But with that C9orf72 gene now being available commercially, we have a lot of options. There was one more question over here, and then I'll get to the internet question.
Hi, yes, for people that live in more of a remote area that don't have access to a multidisciplinary clinic, is there any type of telemedicine service or consultative access where they can take benefit or have benefit of a clinic such as yours?
That's a great question. And telemedicine is definitely something we're researching. Right now, it is not considered standard of care for ALS, and I have patients that will drive 6 hours to come to a multidisciplinary clinic visit. Even if you could come twice a year, it would be worth it. So I would encourage you, at least for now, to try to make the trip to a multidisciplinary clinic. Yes, Jenica, there was an internet question?
Yes, we have one more question and then we'll have to move on.
I have Marcia from the internet who says, my husband has weak throat muscles on one side. He's 77 but strong and active. He's very skeptical of the rule-out testing. He's had an esophagram, EMG, MRI, and is scheduled for a second spinal tap at Johns Hopkins. Which sort of tests really are the best tests for diagnosing ALS?
It's a great question, and the answer is all of them. Unfortunately, with ALS, it's a diagnosis of exclusion, and so all of those tests are important, especially in the situation that's mentioned, to look for all of the other things that it's not, because some of these things are more easily treatable than ALS. So it's very important to be patient and allow the physicians to do a very, very thorough workup to exclude all of those other things. So I think I need to close up now, and thank you for all those great questions. So the next person speaking today is Ilyssa Abaranok, who will be speaking about communicating with ALS. Thank you.
All right, just trying to get situated up here. My name is Ilyssa Abaranok. I'm a licensed and credentialed speech-language pathologist. I do practice here in Southern California, and I contract with the ALS Association to run the Loan Library, which is something that we'll speak about a little bit later in the presentation. So I will just start my contact information. A lot of the times with communication, questions come up later. And so as a speech pathologist, I like to give my information first so that if you guys do have questions later on, you can always get in contact with me. I received my master's at Northeastern University in Boston, Massachusetts, and I'm currently working on my clinical doctorate in AAC, in speech-language pathology. So that's something that's very near and dear to my heart, and we'll spend a lot of this presentation talking about AAC. So that's something I'll share with you. Before I get started, I just want to share some facts about communication. The biggest thing with ALS is that communication happens in stages, and it's a range. So it can range from no effects to complete loss of communication and everything in between. This is why I do share my contact information early on, because as the disease develops, so do the changes in communication. The speech disorder that is associated with ALS is called dysarthria. It's characterized by weakness, tightening, or lack of coordination of the muscles responsible for speech. This can include the lips, tongue, palate, jaw, vocal folds, but overall we're talking about reduces in intelligibility, so how much we can understand you when you speak. Similarly, There can be reduction in breath support, which is something that we just heard about too. This affects communication because we're talking about vocal volume, how loud you are, how loud you can speak. We're talking about how much energy you have for speaking. Sometimes patients with ALS can start off in the early morning with communication and being able to speak, but as the day goes on, that becomes much more challenging due to the energy that they have or don't have. We can have difficulties with maintaining the length of productions, so sometimes you can speak in shorter utterances or you can speak in different procedural methods throughout the day, but this is something that's affected as well. And challenges with swallowing. A lot of patients with ALS have difficulty swallowing food or saliva, loss of tongue mobility or control. But the bottom line and the most important thing that I would like you guys to take home today is that people with ALS often require AAC or augmentative and alternative communication methods to support their daily communication needs. And that's why I'm here speaking with you today. So what is AAC? It stands for Augmentative and Alternative Communication. It involves supplementing or replacing natural speech. So it doesn't take away natural speech, it just helps it, it supports it. It's not just one device or method, but an integration of tools, strategies, and techniques. And the ultimate goal of AAC is to maximize functional and effective communication. So it's not how much you can talk, but what you're saying, what you're able to communicate. When we talk about AAC, we talk about low-tech solutions and high-tech solutions. So the first thing that I'll talk about is low-tech solutions. This doesn't mean lesser than high-tech, it's just different. Low-tech solutions require interactions through co-construction and messages. You can't do low-tech on your own, and that's the biggest thing to keep in mind. Partners need to read, interpret, or deliver the messages of the user. Low-tech solutions tend to be simplistic and unchanging, and they may or not be electronic or portable. So that's something also that needs to be considered when dealing with ALS. Here are some examples of low-tech solutions. A lot of the times we, as natural communicators, can take this for granted. Simple gestures, an indication of yes or no. These are one of the best low-tech solutions out there, and that's simple writing tablets, or even something like an Etch-a-Sketch with a pencil that you can write on. We also talk about things like the E-Tran board and the iTrack board, and those are different methods of low-tech solution where you actually just rely on your eyes to communicate your message. Another form of low-tech solutions are the laser pointers and communication boards. They don't need to be used in conjunction with each other, but oftentimes they are, so I like to talk about them together. The woman in the middle, she has a laser pointer attached to her glasses. Hopefully you guys can see that little red dot. And she uses that to communicate her message. I actually have a video coming up of someone communicating with a laser pointer and communication board, and it can be one of the most effective and fantastic communication methods for patients with ALS. You can see that we have a variety of boards. A lot of them give options that you can write on, that you can change, that you can alternate. But the bottom line is they need to be individualized to meet your daily needs. And that's something that we often don't take the time to do, to specialize it to meet the needs of the actual person using it. And that's the most important thing with communication boards. Here we go. It worked.
I like.
So this is Dr. Richard Olney. He's near and dear to ALS, and so I like to use his video. It's very effective.
It is fast and portable.
So with very little head movement, he's able to share his message. And what you can see is the laser pointer is actually very, very small. It connects to his glasses in this instance, but we also have handheld ones. And the point of it is to be portable, quick, and easy. So it's not something that requires a lot of technology. I know a lot of times patients are fearful of how technologically savvy they are or aren't. And the laser pointers and communication boards are something that can go with you and actually be a very, very effective method of communication across the whole spectrum of stages with ALS. I'd like to share this video, especially because Dr. Olney had a huge impact on ALS and still continues to this day, but he was a big advocate for low-tech solutions. And a lot of the times what we find is people, as they advance, they want the most technologically advanced or the best out there. And oftentimes that is a low-tech solution, and that's something like the communication boards. Now, though, after I just spoke about not needing high-tech solutions, we are going to talk about high-tech solutions. It's not true. A lot of times they are the most effective, but I like to think that they're not the only option out there. Something that I like to say, and before I even go into high-tech solutions, is if you are using high-tech, I always say that you need to have something low-tech on hand also. So it doesn't matter how advanced your systems are. Sometimes we have power outages, sometimes we run out of batteries, sometimes the buttons aren't working. Whatever it may be, there needs to be something else as backup, and low-tech solutions often can be that backup. High-tech options, though, are dynamic, electronic, and integrated. The message is composed by the user. You don't need to co-construct it, so it produces a better sense of autonomy and independence and a lot of privacy that sometimes patients feel they're losing, especially when there are so many caretakers involved. So sometimes a communication device can bring that autonomy back to the situation. There are a range of size and complexities. There's options for visual and voice output, and this includes text-to-speech. So a lot of the times we can use a computerized or synthesized voice to speak for us. You can type out messages. You can use eye tracking or other methods of selection in order to compose a message, and then use a high-tech solution option to say that message for you. There are really a variety of uses for it. High-tech options can store information which can later be retrieved. So we have a lot of patients with ALS who continue in their professional life. They continue to go to work in the morning, and a high-tech device will allow you to store messages that you can then access throughout the day. It's something that allows you to store greater amounts of information, not just simple phrases, and it also allows for you to go as far as to give a presentation if necessary. High-tech options also provide a wide range of interaction partners environments. You're not just limited to that person who understands the low-tech solution that you're using. It's a lot more universal and versatile and who can understand it. So these are some high-tech examples. I always start with iProducts because that's what's the big hype right now. The Apple iPad, the iPhone, all the apps that go with it. Here I believe this is from iChat or TouchChat. We have a yes and no option. iPads are great. This is something that I was just sharing with a couple of families out there today. The tablet is a wonderful form of communication. It's a high-tech communication device that can really provide a lot of options, but there are some limitations, especially if you are no longer able to use hand function or touchscreen abilities. So that's something to think about. There are alternatives out there. The Android tablet is one that I've been speaking a lot about today. These are some text-to-speech devices specifically. We have 2 out of the 3 here. The Swift I don't have yet. Something in the loan library that we work on is donations only. So if it hasn't been donated yet, I don't have my hands on it yet. So we haven't gotten a Swift in yet. But we do have the Dynawrite and the LightWriter. And those are both keyboard-based options where you type your message and you hit submit, and basically it says the message for you. You can also store messages. You can store words to be retrieved later on. And you can also see with the LightWriter at the bottom, there's the option for a communication partner to read what is being written as well. So these are both communication devices that rely on literacy-based learning. You have to understand how to type, how to use that type of information and knowledge first, but they can be very, very effective. I also put on here the website for eTriloquist. This is free text-to-speech software, and you can download it onto your computer. It's amazing. It's really great because you just download it and all of a sudden you're able to type and print what you're saying to speak it. The only challenge with something like this is that when you're using a laptop, the speakers face you. So then the message isn't going out to the communication partner. So I suggest if you are deciding to go with an option like eTriloquist, to get an external speaker that you can face out so that your message goes out to the people and not back to you. These are the highest of the high tech. The two main companies that we work with specifically with ALS tend to be Dynavox and Tobii. Those might be names that you guys have heard. A lot of lingo happens with those two companies. Tobii has representatives here today, so that's great to see that too. These are the more advanced high-tech communication options. They are communication systems. They're built on dynamic layers where you touch one button and it opens up another field to open up another field. But the benefits of these high-tech devices is that you can go so far as to control them solely with eye movements. So if you don't have function of your hand, of your feet, of your body, you can still communicate simply by moving your eyes. And this is amazing technology that we are all thankful to have, and something that your speech-language pathologist can determine if it's necessary or not for you. Our next slide, because I know it's going to start as soon as I switch over, is a man named Augie who's very big in the ALS community as well, and he is speaking solely by using his eyes. And so it's a really great example of communicating through eye gaze. This was a couple years ago.
And when I was starting to find it harder to move my hands, I started to explore software and hardware solutions that might help me stay connected with my friends, family, and business.
Can we try that again? Sorry.
And when I was starting to find it harder to move my hands, I started to explore software and hardware solutions that might help me stay connected with my friends, family, and business.
Okay, it's not playing anymore, and that's one of the unfortunate situations with high-tech technology. And this is why I say you always have a backup low-tech system. I don't have a backup to this, but you guys can get the gist of it is that he's only moving his eyes. He's sitting in front of one of those devices that looks like that computer screen with boxes. And this is actually a web link that I put on the handout, and I really encourage you to watch the whole thing because his wife speaks about how many doors and opportunities it's open for them in terms of communication, and you can actually see the camera goes on the other side and you can see how his eyes are controlling the device. So I apologize, but that's high tech for you. So. The next topic that I'd like to talk about is alternative access. This is something that is not specific to AAC, augmentative and alternative communication, but we use it with AAC. It's compounded on there. With ALS especially, there's a whole range of body parts that are able to access different devices and aren't. And so what we can do in terms of communication is we can create basically systems for you to access a computer or a device or a technology-based system without having to use your hands or something like that. So you can see there's some head switches, some eye switches. The bottom left corner, she's using like a pillow switch and controlling things just by moving her jaw a little bit. There's a young girl who's using a puff switch. She blows air to control and to make choices. We have tracker balls, different joysticks, different foot switches, string switches, buddy buttons. The point is, whatever you're able to use, we're able to help you use it. And we're able to help you communicate with it. A lot of times patients will ask me, well, what's the best out of these, or which one should I buy? And the answer is it's really, really individualized. And that's why I encourage everyone to get in touch with their speech pathologist and have an evaluation done, because they're ultimately the one that can do that problem solving and figure out which would be the best option for you. Another thing that I want to talk about is voice amplification and banking. This is something that doesn't always go into a communication presentation because it's what happens before your voice changes. But I think that that's just as important. It's more about restoring your voice and maintaining it. not restoring it, holding on to it, I'm sorry. Voice amplification, I talked about at the beginning challenges with breathing and breath support. Voice amplification can help that. You can speak very, very quietly and still get that same level of communication without a lot of effort. And then voice banking is newer technology where you can actually record your voice while it's still intact, save it. It can be turned into a synthesized voice that can be later inputted into the devices and used as a closer to your voice than a computerized voice version. So it's really great. You record your voice, and we have these available too. You input it into the high-tech devices later on, and when you push those buttons, or you're accessing communication with only your eyes, it more so is similar to your actual voice. So it's a way to restore that personal quality of your voice longer into the disease and having ALS. Model Talker at the bottom, I just want to point that out, is a free program from the University of Delaware, and they help to do this for you. So that's something that you might want to look up too. The link is on the handout as well. So what can you do now? What can you do today leaving here? I say to everybody, learn how to use your computer, learn how to get in contact with people through email, through text messages, through all of those methods, because as you advance, and you might have to look into those more technologically advanced devices, this is going to be your way of communicating. Learn how to communicate with the internet, learn how to look through things up on the internet, learn how to access things and be comfortable through the internet, where all of a sudden, if you're in that situation and you have to communicate through the internet or text or email, you're not having to add that on top of everything else. When you're starting to see noticeable speech changes, the number one thing is to make an appointment with a speech-language pathologist who knows AAC. Not every speech pathologist out there practicing is comfortable with AAC or this augmentative communication. So that's something that's very important, is to find the right person who can actually help you with some of these solutions. You want to consider voice banking, learn about telephone access programs. That's something that also is very helpful with. Our care managers are very knowledgeable on the telephone access programs. And set up an alert system to call others. So I didn't put any pictures up there, but we do have some examples of the door chimes. That's really so if you're in a different room, you have a way of calling to people without using your voice, without relying on your voice. I just want to wrap up with some contact information about our library. Basically, what we do is we have equipment available in the interim while you're waiting for your own equipment to be delivered. Once you see a speech pathologist, if they're recommending certain equipment, they can contact us, and if we have it in stock, we're happy to send it to you for those 2 or 3 months in the meantime. And these are some resources. The low-tech solutions enabling devices, that's where a lot of the switches come from. Dynavox and Tobii, the 2 big companies, are on there, as well as Tobii Churchill, who does the LightWriter, the text-to-speech device. I see some people copying, so I'll leave that for 1 minute. Maybe we'll leave this up and open up to questions. Okay.
We actually got a door chime today, this morning, and we got 3 of them actually, so that we could have, anyway, our daughters can hear too, not just me, so somebody else can react if I don't. But anyway, we're trying to figure out what to do with the button. How can he have that button on him all the time?
It's a great question. There's lots of options, and again, that's something that's really individualized, so I would have to see what's the best option for you guys. But we talk about SLPs being like MacGyver a lot of the times, and so we're the first to bring out the duct tape and the Velcro, and that's something to try at home. Wherever the doorbell can sit, where it's going to be good, stick it there and make sure it stays there, like on a bedpost or a nightstand. And we also have some options where you can plug in some of those switches or alternate access methods that I showed before to attach to the doorbell. So if there's more foot function, we could set up a foot switch, leave the switch by your feet, and that would set off the doorbell, or different head options, things like that. So it's really an individualized situation, but I'm happy to help further later.
questions?
We had a question from the internet that talked about alphabet boards, low tech, and asked if you were familiar with the communication device that Jason Becker uses, and if you could speak about that.
I don't know which specific communication board he is using, but let me see if I can get back. There are many, many options, and there are many ways to set up different options for different uses as well. The top left communication board is something called AlphaCore. It's a literacy-based alphabet system where the most frequently used words in English by adults are actually organized in an alphabetical fashion. It's proven to be the most effective and fastest way to communicate. And so that AlphaCore board is one of the most widely used with ALS patients. It's really fantastic. We actually have versions of it. Jamie back there is holding one up. That's a copy of the AlphaCore board in the smaller version, and we have the bigger as well. So they can be blown up to any size. You can use this with pointing to point out different words if you're losing the ability to speak. You can use it with laser pointers to point with head movements. There's many different options. This bottom one with the body picture on it, this is another one of my favorite communication boards because it's best for patients who do experience pain and have a hard time communicating that. So what we do is we set this up in a way that you can point or use different means of communicating and have that message still be delivered. So this is a really effective communication board if you're having more of those aches or pains or movement issues that need to be addressed a little bit more quickly, and you don't want to wait to communicate that message. You want to do it pretty immediately. The other alphabet boards can be used to spell out words too. So a lot of the times, like we saw in that first video, you can actually spell the words with boards. The only problem with that is it takes a lot of time. And your communication partner that you're co-constructing messages with has to be ready to predict what's going to come next. So these are the most common used communication boards. Hopefully that helped clarify that a little bit, but I don't know specifically which one they're asking about. Any other questions?
I was just wondering if you could show the second to last. It had some of the resources up there, starting with AAC Library LA at Ilyssa. That's the one.
This one.
Thank you.
The first email connects you to me in the LA area. This is specifically for our loan library, or if you have any questions, you're more than welcome to use that email address. The second one is up in our Bay Area, so that email address will go to Caroline and Amy Roman up north, and they're the ones who will respond to that second one. So depending on your location, a lot of patients travel a lot too, and we'll use both of us. Those are the best email addresses.
Are there any more questions? Any more internet? Oh, one more. Time for one more question.
The question is a general one, and I'll take the liberty of answering it, which is, are copies of the handouts going to be available on our website? And the answer is yes.
Okay, thank you.
All right, so I have the pleasure of introducing David Beals and Brent Zaer, like bear. There you go.
Hi, my name's David, and Brett is the president of our company, and I'm an ATP, which is an assistive technology professional. I've been doing this for 32 years and providing mobility and quite the assistive technology equipment out there. For 14 years I've been involved with the ALS Association and got involved. I was working in the spinal cord world for a lot of years, doing inpatient, and I had a case manager, social worker, that went to work for the ALS Association and was having big time needs, and turned to me and said, "Can you help?" And so that started a whole new world for me. I love what I do. I'm very passionate about all of you, especially the ones that are in chairs. I can't even imagine what it would be like one day to be told what you're told. So I get to be able to go into the homes. I work in clinical settings frequently, but most of my work is done in the homes. And as this condition progresses, I work with everybody. And there's some people that I've been to their homes as many as 25, 35 times. There's some that I see them, 1, 2, 3, or 4 times. Superior Mobility is a company that has allowed us to be able to create a team. So I'm going to talk about us for a few, and then I'm going to get in general. The only thing that I would say to everybody, especially a lot of people online watching, whoever you're going to work with, make sure that they have some sort of affiliation with some of the case managers or the clinics, and that you get options and choices. I think that's the most important thing that you should have, is a lot of choices. And know that you have somebody that's going to be by your side through the whole thing, because I'm part of the support team. One of the things that you guys are coming for today is the research for a cure or for a way to slow this progression or stop the progression. My world is about giving you mobility, and I always tell everybody my goal ultimately is to give you independent mobility and comfort for as long as conceivably possible. And for the most part in my world, that's very possible. So don't let anybody tell you otherwise, because there is a lot of companies out there that you will never hear from again, and that's just, to me, wrong. There are a lot of things that I'm going to show you guys today and I'm going to point out, but you should be able to get in chairs, you should be able to try things, you should be able to, if the cushion isn't working for you, be able to change that out. So that's my first comment. I'm going to go into our slide, and I guess I have control of that. And the first slide is really the world that I really get into. I mean, some of you are here today, maybe in a scooter or one of the power chairs that may have a van-style seat, but ultimately this is the chair they called Group 3. It's dictated by the Medicare world and the insurance world. And how you qualify for these chairs is, unfortunately, I'm one of those that if I had my, be able to make the decision for you, if you were my parent, I'd put you in a chair right away and say, manage this condition, because to manage this condition is going to give you such longevity. To manage stress, to manage fatigue, your stress is very different than my stress in my world. So to manage it and to keep yourself from losing the motor neurons that you will lose, being in one of these chairs, and you can see by one of the chairs I've got out here, they tilt, put you back in gravity, they recline, they elevate their legs. You can have a power seat. I'll talk in a little bit about the alternative drive controls electronically, what you can do. And again, I just met David a few minutes ago. David needs to be able to be functional for the rest of his life, and that's, to me, what it should be about, and me being able to offer that to him and give him those choices. So when it comes to these, all of those features are critical. The biggest problem that we have is getting them funded. These chairs, as you're looking at, they're $30,000 wheelchairs retail. In the insurance world, they pay us about $22,000, somewhere in that neighborhood. So when you're seeking out chairs like a few of you have, these chairs are available, but if you buy them up front and you get them before you get qualified for the bigger chairs, you lose your funding. So always be very careful, and at the end I'll talk about loan program. The drive configurations are critical, and again, you should be able to know these things. You've got what is called a mid-wheel versus a rear wheel or a front wheel, and each one has some advantages. The chairs I'm showing right here today is that one, what Brett is showing, is a front wheel. And the front wheel drive, probably the biggest advantage to that is outdoor use. It's tremendous. It's going to do things so much different than any other chair out there. But its turning radius is much longer, so its footprint is longer. For years, the front wheel was probably the preferred choice. When it comes to alternative drive controls, and that's something, again, I'm going to talk in a few minutes about, meaning you're not driving with your hands, the front wheel can have some advantages. So I explain that out when a person is starting to look at these chairs to see the differences in them. The one to the right is a mid-wheel drive. So that is going to be one that the wheel is right above you. So functionally, how one works in that chair is very similar to how we operate. If I want to turn to look at this, I just turn. With the front wheel, the wheels are in front, it's got a different kind of motion that pulls you around. Whereas the mid-wheel, you push to the side, it's literally turning just in its space. So again, with alternative drive controls, it works very, very intuitive, the way that you would want to drive a chair. So that is the mid-wheel. I didn't bring a rear-wheel drive. I don't generally recommend the rear-wheel drive in my ALS community because it's very long, it's very bulky, very challenging. And many people don't live in super small houses, so the mid-wheel drive is the preferred choice, and that's a chair that Permabil, who's in the back, came out with, and it's a preferred chair of the ALS community for several reasons. One is that electronically what this chair can do, again, over the entire use of the chair, and in the insurance world, they expect them to last 5 years. You should be able to adapt. You should be able to have all the features that you need. And some of the chairs out there don't do that. From an adjustability standpoint, this chair will do unbelievable. So let me go to the next slide because I'm getting ahead of myself. So qualifying for these chairs is my biggest challenge. If you just today said, I want a chair, and you were still walking, it becomes very difficult. So if you're walking with one of these walkers, or you're able to push a manual wheelchair, or you're able to drive a scooter, or even to drive a power chair, and still can transfer, then you don't qualify for what's called a Group 3 chair, which has got multi-positioning capabilities and electronics. These all here are going to be certainly much less money, and so that's the way that they look at it. So again, Lone Pull, I'll talk at the very end, is where you might be able to seek out some of these, or the walker up there, Costco now sells them. You know, you can get them at CVS Pharmacy or any of the local DME companies. So those walkers are actually really nice. When it comes to a manual wheelchair, that's an ultralight wheelchair. It's made of high-impact aircraft aluminum. There's titanium, but you get into a $3,000 or $4,000 chair that has to be custom fitted. So if you can push that, though, it makes sense. I come from the place that I tell everybody, manage your condition. If you use it, you're going to lose it. In a lot of conditions, if you don't use it, you will lose it. This is about managing your condition, keeping it for as long as possible. Keep your hands, keep your arms, keep your legs, because transferring is critical. So when you go from the bottom right chair, which is a Group 2 type chair, they call it, it does have the ability to have a semi-recline. It's a van-style seat, so it's like a car seat. But from a comfort standpoint, and when I'm going to be getting into a seating and positioning, things like that, to sit 6, 8, 10, 12, 14 hours a day in one of these chairs can fatigue your body severely. And so even for all of you sitting here today in these chairs, you will notice how worn out you get. So again, these chairs change that because you can move your body around. So but to qualify is the big key, and that is going into a multidisciplinary clinic is the best way because you're going to be able to see all the different disciplines. But the physical therapist or occupational therapist is going to have to qualify you that you no longer can transfer independently, or that you're falling too frequently and you possibly are injuring yourself. Or the next phase is that you're not actually able to do things by yourself, to where you actually have to go into this to be able to perform your mobility-related activities of daily living. So that's a big buzzword out there. So let me flip to the next slide. So the next part, if you do get qualified, proper assessment and the evaluation to me, again, is critical. And all of you should have this done at home. I know sometimes clinics, you'll do wheelchairs. I used to actually spec the chairs in clinics, and I found that that really wasn't the proper way, that I needed to get into the home and spend, and in my case, I spend the entire day for an ALS individual and give an entire day to being able to see the different chairs that are out there, even if you want to see the other manufacturers that exist out there, to try different cushions. And Brett, you might want to show everybody that one cushion. There are amazing cushions that are being developed today that have a tremendous amount of technology into it. Some of the cushions, if you don't have this condition, you would not qualify for it. So this one happens to be called a J2 Deep Contour, but with this cushion is one that has no memory. So technical words is that it decreases the capillary pressure below capillary pressure, so it allows for the blood to flow, oxygen, nutrients, and this is the part that you sit on, and it is an amazing cushion. But what's underneath it, it's even more amazing, is that the part that holds you in place is for stability and support in a very uniquely different way. And my feedback from clients that I've worked with, and the other cushion there is a Rojo. Many of the professionals out there will just automatically put a Rojo out. The Rojo is an air cushion, amazing pressure management, comfort, but it has very little positioning. And positioning to me, again, when I start talking about stress and fatigue and stress, I was talking to David earlier, and the chair he's in is fitted for his hips, but it's not necessarily fitted for his trunk. And to have that with him causes him to lean, because when he came over, he was leaning ever so slightly. Well, that's very fatiguing when you spend an 8-hour period of time. So to have a chair that's actually fitted very tightly, to have the back adjustable, the arms adjustable, not only arms adjustable, the arms independently adjustable, and having 4 or 5 different adjustments to it, to having adaptations be able to add it. As you saw with Augie, he has that communication device attached to the chair. Some of these chairs, it's almost impossible, and it takes, literally an act of Congress to get it done. This is a chair that it's easy to adapt. The ACC companies absolutely love this chair because it's adapted for it. But to be able to drive with these things very balanced is also another thing, to have some of these things adapted to. So, so with the home evaluation, you're talking about being able to look at the entire environment, because if you're just buying a chair and you don't look at stairs, ramps, doorways, how you're going to fit it possibly in a bathroom, is the bathroom manageable at all? When you get a chair like this, they don't fold up. You've got to be able to get a van. And so the van is something that I don't sell, but I certainly can give a tremendous amount of recommendations to. And companies like us should be able to be looking at that. If you get the van first, it can be a disaster. I talked briefly on seating position. Let me go it through real fast because I'm going to run out of time. Hips, pelvis is the key. So if you ever see anybody sitting in a chair and they're sitting crooked, look at their hips first, because it all starts at the hips. And if the pelvis is crooked, the whole body becomes crooked. Again, why these cushions are so important is they hold the pelvis in place. With head and neck issues, it starts again at the hips, but the head and neck, some of these like this headrest here, is multi-positional. You have the ability to easily adjust it. It takes 1 wrench and can be shown to any family member. Circulation is critical. Edema is critical. Those are things that can kick in, and I've seen some of the most horrific edema in ALS as one sits for long periods of time. And the constant thing that I've had people say to me is not that they're uncomfortable, it's that there's a discomfort. It's something that is uniquely to ALS that I don't run into with any other condition, and that is that they're not moving their body. They sit statically, and so therefore their bottom side is just so sore. Well, again, when you have the ability to use your legs back independently and tilting, all of those things can change significantly. But if you're sitting on just a regular foam cushion, it doesn't make it do the kinds of things that other cushions can do. And then when you're not sitting correctly, you've got bowel, bladder, your intestinal tract, your breathing, which is already compromised, your swallowing. So as you sit better, it can do a lot more managing. And as I always run into, I talk, I guess, too slow. I'd love to speak on this to all of you, so I'm here, and if anybody needs to talk to me, I'd be more than happy to. So I'm down to about a minute. So let me do this real quick. Alternative drive controls, I have just a few that I was going to show you. There are things that you can do with just slight movement. There is switch control for head. There is even a brand new one that just came out that is literally a touch control. You just touch it, and wherever you're pushing towards is where you'll be able to drive. All of these things are adaptable. There's a lot of other equipment out there, but let me get to the loan program. That is very important. So with the ALS Association, we're tied closely with them. We do Southern California, and every community has a loan program, and there are these chairs that are available. Further, if you ever don't need it anymore, please donate it back in, because to get spec'd up for a chair, it can take 2 to 3 months to get your own custom chair, to go through the clinical setting, to get all the documentation, all the things. There's lots behind it all. These chairs are available under the loan program, and you can borrow them until your chair comes in or until you qualify. So if you're feeling like, I don't quite qualify, I'm still walking, and you need a chair, it's just a phone call to your case manager at the ALS Association, and they'll get you aligned with us, and we can provide that to you pending your having the need, or getting your van, or getting your house done, or whatever that may be necessary. So it's a free service. All the donations that you see is what helps that make that possible through, like the golf tournaments and the walks and things like that. And again, the best and most important thing is the case managers. They are huge in your world, can be a tremendous asset to you guys, because they're the ones going to be working alongside you, working at the multidisciplinary clinic as well. So I'm now down to a minute. So questions? Any questions or thoughts? Minutes goes by fast. Since there are no quick questions, let me just say one. Oh, go ahead.
Sorry.
Are any of the cushions covered by Medicare?
Every one of them. If there's a good news about ALS is when you qualify, you're qualifying for the best. You can get the best. And I mean, the one thing that and I'm going to speak for myself, that I believe in, is that if you get a cushion and 2 months later it's not the right cushion, you sat on it for, say, 10 minutes or half an hour, and you felt it was right. In our world, we change it out. It's a swap out. We'll work with you. That doesn't always happen. That should happen. But there are, in the loan program, some other cushions that you can get as well. So pay very close attention when you're going through your evaluation to make sure you sit on and try the cushions. And with the Rojo cushion, if anybody has one out there, I'm not going to talk about it now, but you're welcome to call me. There's a proper technique behind the Rojo cushion that isn't explained enough, and you can be overinflated and uncomfortable, under-deflated and not comfortable, or there's some other things that go along with that. So, any other questions? Go ahead.
I don't have a question. I just want to tell from our own experience that you need to be very, very careful when you're selecting at the time of selection, because Medicare buys a wheelchair for you only once every 5 years.
Correct.
And if you buy, let them buy a $500 one for you at the beginning after your diagnosis, then you don't get the $28,000 one later.
That's correct.
Until after 5 years. So just be really careful.
It's very difficult.
Can you go back a picture or two that showed the devices in the bathtub? Yeah, that's it. Thank you.
I'm sorry, I wasn't able to explain, but so if you don't have the financial ability to afford to do a modification to your bathroom, which is ultimately the best way to go, what I have in front of you here, if you want to come up, you can look at it. It's called the Shower Buddy, the Tub Buddy. They make two, and they have a tilt one. They're online. You can get them from lots of different companies. We sell them as well. But it is a great device that allows the ability to slide across and slide out, and then you can wheel out, go to a long-sized bed, alongside a wheelchair, and transfer. So you can minimize your transfers, and they actually really do work. But you should have an in-home evaluation done if you're going to get one, because it needs to make sure you have the room. I saw another hand. Go ahead.
What was the name of that two-part cushion that you held up?
So this is called a J2 Deep Contour. Sunrise Medical is the manufacturer. J Medical created this many years ago. Now there are several layers of cushions. There's actually 2 brand new ones that just came out that for the ALS community, I think they're going to be incredible. One's called the Fusion. What's the other one called, Brett? The Ion and the Fusion. I absolutely love the cushion. They're a little thicker in size, but when you're sitting tilted and you really are needing them, it's going to be, to me, my second cushion. The J2 Contour is the most preferred cushion, secondarily to the Rojo cushion. So is there any online questions?
Not yet.
Okay.
Question?
Is there another question back there? So let me just say one last thing. I have a client that I recently fit for a chair who's been in a chair for 18 years. Same permeable chair for 18 years. 38 years she's had this condition. She's the second living that they've found out about. I asked her a question and I said, so what's worked for you? And what she said is to get out of her own way, to live her life. And I remember a client of mine asking me one day, and called me specifically and said, can you tell me about how I'm going to die? And I said, no, I'm not going to talk about dying. I don't like talking about dying because I believe that every one of us are going to die one day. I talk about living, and that's what she does, and what she has done for 38 years is live her life and not let this get in her way. So I can't emphasize it enough, and certainly chairs amongst all these other things, and things that are being talked about today as this research goes on, which is amazing what's going on today. Please live your life, have fun, enjoy. Augie is a classic example of that, Nieto. So.
Any more questions?
There was a question on the internet that talked about purchasing devices directly rather than working with someone to help fit them, and whether or not you would recommend that.
So purchasing directly, well, I mean, anybody can, but I can't tell you, I have a team, and we are deeply involved, and we get paid one time. We don't get paid for going out there over and over. Where is the hand control? Sabrina, do you have those? Little things. I have gone out to clients' homes that was frustrated, and the case managers have referred me out. I didn't sell the chair. And these are joystick controls that can literally keep you driving 6 months, a year. I went out to a client who I was told he couldn't drive anymore, and he was in a Rojo cushion. All I did is changed his J2 Deep Contour, adjusted his arms, did a little bit of programming, put on this device here, and he drove for 1.5 years. So it took me hours. no funding for that. There is not funding for that available, but I did it. You can find companies to work with. That's the difference in being able to work. There's going to be those needs, and those needs are monumental. And so somebody told him he couldn't drive anymore. I mean, that's just doesn't make sense to me. You can keep people going for a long, long time. And then there's attendant controls, which is in the back of this chair, that you can get, which can be also very advantageous. So, is that it? Okay. Thank you very much.
Thank
we're
you.
around if you need to ask any more questions.
This concludes our session 1 of this program, so we're going to take a 30-minute break. There's some more refreshments outside. Feel free to go and visit all our vendors. We have Permobile, Toby, we have ResMed, Home Respiratory Care, the Beauty Bus Foundation, and of course Superior Mobility. We will reconvene here at 5 p.m., at which time the researchers will be coming in to talk about for our session 2, which is the latest update in research. Thank you.
And for those of you who are watching on the internet, please don't disrupt your stream. We will have some videos for you to watch for the next 30 minutes. Thank you again.
take me another 3 months after diagnosis to realize what my journey would be. I've learned to slow down and enjoy my life. I'm not willing to give up. I believe in research. I think there's an answer. I would love to write a check and sign it. and I needed someone to be with me all day while my sister works. The chapters help me in a lot of ways in my day-to-day life. They're all there fighting for me, and that's what you need, you know? Thank you.
My name is Michael D'Aries, and I was diagnosed in 2001. My pinky wouldn't extend up all the way. Most of the progression has been muscle mass loss in my arms, my chest, a lot of fatigue. ALS was the diagnosis. After 7 years, I feel great. I'm one of the fortunate ones. So there is hope. It's not always a clinical 2 to 5 years. I was able to watch my son grow up from the age of 2 until 9. Actually, what I want to do is get the record for the longest living patient with ALS. That's my goal.
Scott was originally diagnosed in August of 2002.
My first symptoms were twitches in my arms.
My first symptoms were twitches in my arms.
And telling really bad jokes.
Telling really bad jokes.
That part didn't go away.
That part didn't go away. I took off my shirt and my arms and chest were twitching. And the doctor looked at me and said, "That's ALS. That will kill you in 2 to 3 years." And I freaked out.
And then he backed off.
And then he backed off.
And that was a crazy day.
And that was a crazy day. I told my parents, and that was pretty...
That's the one phone call.
That was the one phone call
You don't want to be making.
you don't want to be making. One thing I realized,
I liked food a lot more
I liked food a lot more
than I thought I did.
than I thought I did. One day,
You're gonna get back in there.
you're going to get back in there. What are you going to start with?
Or, lamb chops.
Lamb chops? Okay. All right. ALS.
Or the trust fall.
It's like a trust fall.
Or fall backwards.
And you fall backwards. Somebody is there to catch you. There are just so many people that help.
I don't know why I'm not laughing.
I don't know why I'm not laughing.
I need help to breathe.
I need help to breathe.
My name is Cheryl Payne, and I was diagnosed on May 22nd, 2008. My first symptoms were on the left side with my hand. I was actually pregnant with my twin boys at the time. In January '08, I started noticing difficulty speaking. I enjoy reading to my boys, and it's now difficult. It's limited me in what I can do, but it hasn't destroyed my spirit. I wish I could still run. I have 3-year-old twin boys, and they love to run, and they'll come up, "Chase me, Mommy." I have a lot of life in me to live. I truly believe that each moment is a gift, and I don't intend to waste it. I wish they could know me before the illness, when I could run and dance. I wish for a cure for this disease. The disease has taught me to open myself and let others help.
Thank you.
What if one day you could no longer speak, walk, feed yourself, or breathe without support, yet you could still think and feel every emotion? That day has already come for thousands of people with ALS or Lou Gehrig's disease, a deadly disease with no cure or effective treatment.
ALS has already destroyed my ability to do many things I love, but with your help, we can find treatments and a cure. Join in the fight against ALS.
And join in the fight for hope. Visit actionals.org.
With its iconic lines, powerful 5.0 supercharged V8 engine with methanol injection system, and its head-turning red chrome paint exterior, the ALS Awareness Mustang carries on the classic lineage of the Mustang brand.
You say to yourself, what's Mustang? The first thing that comes out of your mouth is the bullet. But Steve McQueen, an iconic person himself, has made Mustang very, very famous with the San Francisco chase scene. And me as a child growing up and seeing it older, and even to this day when I see it, I still get excited about watching that car going through the landscape of San Francisco.
A result of the combined talents of Gary and Kristen Watson of Creations in Chrome, along with Melvin Betancourt, the ALS Awareness Mustang was expertly crafted to be the centerpiece of the Golden West chapter's Rev Up to Defeat ALS campaign and a symbol of one man's battle against the disease.
The reason why I wanted to customize this Mustang for ALS was because I have a close friend that's been stricken with the disease. And I was present with him when he was diagnosed by his doctor. And to witness that, it was crushing for me. And at that moment, I knew that I had to do something to raise awareness for ALS and to do something for Kerry Hall.
What inspires me about Kerry and the way he's handling his ALS is that he still goes to work every day. He has 2 young boys and a wife. They do everything together, and everyone in the chrome industry has kind of rallied around him and helped him.
With Kerry in mind, work began to develop a stock 2012 Ford Mustang into a one-of-a-kind classic.
Gary and I have kind of this dynamic that we just kind of constantly bounce off ideas. And then I drew up a picture and he says, that's it, I love it, that's the vision. So we just went from the front to the back, to the interior, to every nut and bolt. Gary's kind of a perfectionist, which is kind of cool. I beat him up all the time, but you know, we do have a good dynamic, good working relationship.
We actually got the car 5 months before SEMA, which is really kind of unheard of to get the car that early. Usually you have about 10 weeks to build the car. And we got to put a lot of attention to detail in the interior, under the hood, and obviously the stunning chrome paint on the outside.
It's at this point that legendary driver and member of the Motorsports Hall of Fame, Parnelli Jones, joined the team as the Rev Up campaign celebrity spokesperson.
Well, racing has taught me a great deal about life because, you know, first of all, automobile racing is very dangerous. Back in the 60s and 70s, it was a lot more dangerous than it is today. Every time we lost a driver or something like that, it was like taking a piece of your body away from you. You know, it makes you feel like you're giving something back to society. I mean, I've had a great life. I'm very comfortable. I feel the obligation to, you know, do what I can for charity.
Well, one of the things I would love for this Mustang, this beautiful red chrome Mustang, to make people more aware of the ALS disease. The Mustang's a great vehicle for it. It brings a lot of people to look at it, but at the same token, there's a story behind it, and it's a true, powerful story behind it.
On the track, the ALS Awareness Mustang is an awesome combination of speed and beauty. Yet the car's true power will never be judged by its lap times. Instead, it will be measured by the number of hearts it can touch and the minds it can reach in the race to save lives.
If you don't know anything about ALS, better known as Lou Gehrig's disease, know this: it attacks your body. Eventually, your body will stop working. Your legs, arms, your lungs, but your mind still works. You know what's coming, but you can't do anything about it. But with your support in funding global research, the ALS Association can help people with ALS do this.
Fans, for the past 2 weeks, you've been reading about a bad break I got. Yet today, I consider myself the luckiest man on the face of this earth. I may have had a tough break, but I have an awful lot to live for. Amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, is a progressive, fatal disease that attacks nerve cells and pathways in the brain and spinal cord, causing the body's motor neurons to waste away. Tragically, there is no known cause and no known cure. When it strikes, it changes everything for the person with ALS, for family and loved ones, and for everyone whose lives are touched by the disease. Lou Gehrig said he felt like the luckiest man alive, not because of the tragedy life dealt him with ALS, but because his disease helped him see and appreciate what is most significant about life. There are many affected by ALS who would agree and who would commit to living their lives as fully as possible, even when facing the challenge of the disease.
My spirituality allows me to experience life in a much richer way. So everything around me takes on a brighter facade. I feel as if I am seeing reality in a much different way.
I recognize that I don't have a long time yet, but I'm going to take every day and try to find something that's good about that day, something that I'm grateful for. And it's wonderful. I mean, that's another thing I didn't do with my life before.
The ALS community, you and I, are the heart of hope for people living with the challenges of the disease. It is overwhelming to deal with ALS alone, and that is why the mission of the ALS Association is so important.
In terms of the ALS Association chapters, I could not do the work that I do without the chapter. The chapter gives breadth and depth to what we do in the clinical centers. The clinical centers are the jewel in the crown for the chapters, because we provide the care that increases quality of life, increases length of life, and that's now been documented in a number of journals. This makes my life worthwhile.
The ALS support group, it's made us feel not alone. And with this disease, you kind of stick out in a crowd, you feel alone. And to gather with a group of people on a regular basis and be able to talk about the things that we all need to talk about and address the issues that we need to address has been just a lifesaver for Leo and I, and we are eternally grateful and will always be grateful to the support group for the support and love and friendship that it's given us.
I met a series of people who were suffering right in the middle of their lives. And I realized I was working with heroes every day, whether it was the patient who was the man trying to kind of soldier on, or a wife who was giving up everything to take care of her husband. You'll never look at your own life the same way again.
When you feel out of control and you just need to rail at the world, the association has opportunities to volunteer, but also the walks, organizing friends and family to be able to raise money that we knew then stayed within the ALS community. It didn't just kind of go into this big pool of money somewhere.
People often think they're throwing money at an organization. They don't know where it is going to go. I have a walker. I have a wheelchair. Thanks to the ALS.
It is our commitment to work relentlessly to create a world without ALS, to leave no stone unturned in our search for a cure. The future decade is about knowledge fueled by innovation, new technologies, and hope. Thanks to an amazing convergence of science and technology, we have the tools for the first time to unlock the mysteries of this heartbreaking disease.
I make my living during my day job, but I feed my soul through my work with people who have ALS.
Because of your generosity, our chapter now has the opportunity and capacity to fulfill our commitment to the ALS community. We have done much in the past 10 years, and we will do even more with your help. Help us eradicate ALS so that no one will ever endure or live with the threat of the disease. Help us change the world, one life at a time.
Matt Cheney is graciously agreed to be the bike cam today.
Rest, my dear, it's alright. Angels watch over you tonight. And there's nothing left to do with the things you never knew, all the things you never knew. Now you know that all your life, how you felt like things were turning, but for all your life, it just feels like things were wrong.
When I was diagnosed with ALS, I made a conscious decision not to allow this disease to define me. I have continued living a full life, doing the things I have always liked to do, and modified them as my limitations grew. I have tried to make the most of my life, spending time with the people I love, and focusing my attention on recovery.
The phrase, strength of mind, body, and spirit, epitomizes Musa Malik's journey throughout life. From a very early age, Musa displayed an instinctive passion for living. As a natural athlete, he excelled at a number of sports. As a businessman, he built and ran a highly successful real estate investment and management company. And as a family man, he embraced the role of husband and father, dedicating much of his time and attention to his wife and 3 children. Musa was a self-made man, living each day by the motto, "Enjoy the moment."
Musa was always a very physical man. I would call him an extreme athlete. He really was. Everybody looked up to him for his athleticism and his physique and the way he carried himself. And But I think when you're stripped from all of those physical attributes, what is left is what is inside, and those kind of get exaggerated, and you really see it come to play. I'm amazed of what a strong person he is.
So when you meet Musa today, 6 years after being diagnosed with ALS, living in a body that is slowly being ravaged by the effects of the disease, it's easy to overlook what he has lost in physical ability and be impressed by a man that exudes the same strength, determination, and love that has become embedded in every fiber of his character, as he refuses to let ALS conquer him.
I have been able to cope with this illness by focusing my attention to recovering from it. I meditate daily. I visualize myself healthy and active. As my limitations grow, so is my desire to beat this illness.
His regimen also includes regular trips with his wife to the ocean, where he finds strength in his connection with the sea. This combination of disciplines allows him to harness the mental and physical powers necessary to face each day with a commitment to enjoy every moment, moments that are now much more meaningful than ever before.
He finds things to enjoy, and he makes the most out of the situation.
Right. And he can look back now and say he didn't regret not doing something or not going somewhere, not taking advantage of opportunity, because he always has lived in the moment.
Yeah.
Yeah.
Doesn't waste any time.
No.
My dad is always on the go.
Go, go, go.
Today, Musa still serves as a teacher and mentor to both family and friends, imparting his wisdom, not so much with his words, but through his actions.
When they come to him with problems that they see as big problems for them, when they see him with all his challenges, dealing with it peacefully and gracefully, they kind of go back home and they say, we have no problem. Life is great. They find that what it seems big to them is really nothing.
For the past 6 years, Musa Malik has faced ALS head-on and has not backed down, choosing instead to stay focused on what he and his family feel certain is waiting just around the corner.
Living with ALS has given me a much sharper focus, more time to reflect and appreciate my life, and all the personal connections, love, and friendships I have formed. I consider myself a lucky man to have lived a balanced, full life, interconnected to many wonderful people.
Lou Gehrig's disease has robbed me of the ability to tell my husband I love him.
To hug my granddaughter when she cries.
To serve my country. But I can still celebrate with family and friends.
Feel the excitement of the crowd.
This is my walk to show people that ALS doesn't define me.
This is my walk to defeat ALS. Help the ALS Association in the fight to treat and cure Lou Gehrig's disease.
Walk to defeat ALS.
Dr. Neil Browerman was a man at the top of his profession. At the age of 38, he was a renowned retina surgeon and ophthalmologist, martial arts enthusiast, a husband and father. By all outward appearances, Dr. Browerman had all that he worked so hard to achieve. But in 1997, it all changed for Neil and his family when he received the diagnosis of ALS.
Saw Jasper Dalby, who had written many, many articles. He was a big guru in ALS. And he told us in so many words that he thought he had 6 months to a year to live.
One extreme is someone like Stephen Hawking, who can have it for 20 years. The other extreme, which is the very fast version, like what my brother has, in which he went from fully functioning to being on a ventilator in the course of less than 1 year.
You believe a lot of people with ALS can live longer and more fruitful lives, don't have to think about dying, don't have to be as depressed as they might be, through learning more.
The vast majority of people who die with ALS die from respiratory failure. Often suddenly, and the reason they die suddenly is their doctors wait too long. They don't put them on ventilator. The quality of life of patients with ALS on ventilators is quite high.
Now, 7 years later, Dr. Browerman lives in a condition which is referred to as being locked in. He has no movement or speech, no ability to eat, drink, or breathe on his own. But inside his body is the same man, with the same mind and spirit, a spirit that allows him to continue on.
He's one of a kind. He's phenomenal. He has a tremendous will to live, and from a parental standpoint, we're extremely, extremely proud of him.
By using a ventilator, Neil has been able to stay alive, allowing him to pioneer new methods of alternative communications for ALS patients. Neil now conveys his feelings through the use of a polygraph machine, a method that, until he adapted its technology, had never been utilized for this purpose. This now serves as the only line of communication between Neil and his family.
Can you give these guys a big high five and tell them just a welcome? Give them a big high five so you can tell them a welcome because they're making this film for the affair. Look. See?
That's great.
Uh-huh. What we do is when that line is straight and thinking of a blank wall, that's a no answer. You have to get yourself excited, and then the line goes up, and then that's a yes answer. So Neil can control it that way. Jack Tremarco said, he was so excited, we all started screaming. He said, it works. And he said, very easily. And he said, you've made my year. I said, Jack, you've made my life. We've got him communication.
The Browerman family has been a major source of support and encouragement for Neil. Together, they created the Neil Browerman, MD, ALS Research Fund, established to find a cure and effective therapies for ALS. Since its inception, the family has donated and raised close to $1 million for the fund.
He really feels there will be a cure, and that's what he's working on. His name is out there everywhere. We're fighting to raise funds to help these scientists come up with a cure. There's more research going on now than there ever has been before. And it will come, but it takes money, and it takes people working on it.
We need to raise awareness. We need to get our politicians involved. And much more money needs to be put into this.
Even with his body struck down in the prime of his life, Dr. Neil Browerman's work continues on. His efforts today improving the lives of the ALS patients of tomorrow.
He's not a fighter, he's a warrior. I marvel at his spirit. I marvel at his love, and I marvel for his want to stay alive.
Dr. Browerman